Ladies and gentlemen, thank you for joining me. MPRO's Smoking Cessation, Counseling Within Clinical Settings. Your host for today, Julie Campbell, will begin.
Good afternoon and welcome to today's webinar presented by MPRO entitled Smoking Cessation Counseling Within the Clinical Setting. This event is part of our Michigan Cancer Control Initiative, which aims to improve cancer screening rates throughout Michigan. If you'd like to learn more, please visit cancercontrol.mpro.org. If you would like to download a copy of today's slides, they'll be uploaded to our website, and again, that's cancercontrol.mpro.org under the lung cancer section. Today's speakers are Patricia Heiler, Public Health Consultant within the Tobacco Section at the Michigan Department of Health and Human Services, and Dr. Vida McCabe, Regional Medical Director of the Lung Care Program and Tobacco Cessation Programming at St. Joseph Mercy Health System. We will hear first from Patricia about the physician's role in tobacco dependence treatment and effective ways to advise patients to quit. Dr. McCabe will then give us her perspective on tobacco cessation counseling using pharmacological and motivational interviewing strategies. Participants can feel free to submit questions via the chat box at any time during the presentation. However, in the interest of time, we will address these questions and the ones that are in the phone queue at the end of both presentations. At this time, I would like to turn it over to Patricia.
Thank you very much. I was asked to present today on how you, as healthcare providers, can treat tobacco use independence in accordance with the United States Public Health Service Clinical Practice Guidelines. Also, throughout this presentation, I will highlight ways that you can effectively change your policies and protocols to ensure that tobacco dependence treatment is fully integrated into care and sustained over time, over and above the direct treatment delivery to any one individual patient. Tobacco dependence is a chronic disease because, similar to diabetes, heart failure, and hypertension, there is an expectation for remission and relapse, taking as many as 7 times for an individual to quit using tobacco for good. Clinicians play a very important role in treating tobacco dependence. Specifically, ongoing treatment involves providing counseling and support and prescribing appropriate pharmacotherapy, all of which you'll hear throughout today's presentation. Tobacco dependence should also be considered a chronic disease because there is a spectrum of disease severity. Effective treatments are available. High-dose and multi-drug regimens may be necessary to achieve these target goals, just like in diabetes and hypertension. And treatment may require referral to specialists. And as you will see throughout this presentation, individualized therapy is very important. As few as 3 minutes of counseling can increase the success rate of tobacco cessation. The 5 major components of tobacco dependence treatment are featured here on the screen and are oftentimes collectively referred to as the 5 A's intervention, which stands for ask, advise, assess, assist, and arrange. As mentioned earlier, the physician need not deliver all elements personally. One clinician, for example, a medical assistant, may ask about tobacco use status, and the prescribing clinician, perhaps the physician or dentist or nurse practitioner, may deliver the personal advice to quit, assess willingness to quit, and prescribe medication, but then refer a patient to a tobacco intervention resource, such as Michigan Tobacco Quitline or an on-site health educator that would then deliver intensive personalized treatment for that patient. The clinical practice guidelines emphasize the importance of clearly identifying staff roles and including tobacco dependence treatment components in position descriptions when hiring staff. Also, it's important to have tobacco dependence treatment coordinators on your staff to ensure that evidence-based treatment is provided in a timely manner and clear communication can be maintained for consistency of care. Systematically identifying all tobacco users at every visit is important. A healthcare provider should ask every patient whether they use tobacco, no matter what they are being seen for at that clinic visit. Ask specifically what type of tobacco is used. how often, and how long, and if the patient has tried to quit in the past. Remember to ask about all types of tobacco, including hookah and e-cigarettes, because many of your patients may not understand that these are indeed tobacco products. It's important that you implement an office-wide system that ensures that every patient at every clinic visit is asked about their tobacco use. Patients are more likely to quit, according to research, if advised to do so by a healthcare professional, and are more satisfied with the care that they receive. So it's important that in a clear, strong, and personalized manner, you urge every tobacco user to quit. Advice should be clear. For example, say to your patient, it is very important that you quit smoking, and I can help you. Your message should also be strong. For example, say to your patient, as a clinician, I need you to know that quitting smoking is the most important thing you can do to protect your health now and in the future. Ensure to them that the clinic staff will help them in their quit attempt. Your message should also be personalized. It is important that you tie their tobacco use to current symptoms and health concerns, and tie it to social and economic costs, or the impact of tobacco use on their children, their pets, or other things that the patient cares about. For example, say to your patient, continuing to smoke makes your asthma worse. Or, if pertinent, state, quitting smoking may reduce the number of ear infections your child has. The next step in treating tobacco dependence is to determine the patient's willingness to make a quit attempt. Simply ask your patient if they are willing to give quitting a try. For example, say, are you willing to try to quit at this time? Or say, are you thinking about quitting within the next 30 days? This not only provides you with more information about the patient and how they see tobacco fitting into their life, but it is important to gather as much personalized information from that individual and meet them where they're at in their readiness to quit. If the patient is willing to quit, help the patient develop a quit plan, recommend the use of approved medications, and provide practical counseling, such as assistance with anticipating challenges, relapse, tips on how to build on past successes and avoid triggers. It's important to provide a supportive clinical environment which encourages the patient in his or her quit attempt. It's very important for the health system that you work in to have a strong, comprehensive tobacco-free campus policy. It's important that none of the reading material in your waiting room contains tobacco-related ads. It's necessary that everyone on your clinical team have access to supplemental material and know about the Michigan Tobacco Quitline and other evidence-based tobacco dependence treatment programs that they can offer to the patient. Have printed material on hand and available to provide to all your patients as you're progressing through their quit attempt with them. If the patient does clearly state that he or she is unwilling to make a quit attempt at this time, provide access to staff that has been trained in motivational interviewing strategies. Nicotine replacement therapy is an alternative way of delivering nicotine to the brain, and as you know, it comes in several forms that can be used alone or in combination. Nicotine replacement therapy does provide safe ways of relieving cravings and can help your patients as they progress through their quit attempt. It's important that you and your clinical staff know about the approved medications, as you see listed here on the slide, and have access to handouts to provide to the patient as they're discussing and assisting the patient in quitting. All smokers trying to quit should be offered medication except when contraindicated. And there are these 7 first-line medications approved by the FDA to treat tobacco dependence. To ensure that patients are treated to the guidelines, develop strategies such as standing orders, direct provision of over-the-counter medications to ensure that the patients receive these medications. And it's important that you and all your staff know that as of January 1st, 2016, both Medicaid and the Healthy Michigan Plan cover all 7 Food and Drug Administration approved medications without prior authorization, without step therapy, or annual or lifetime quantity limits. Nicotine replacement therapy should be considered for anyone who smokes greater than 10 cigarettes per day, anyone who reports withdrawal symptoms during a last quit attempt. It is important to remember when prescribing nicotine replacement medications that each quit attempt is different, so it is okay to try same medications again as motivation may have shifted. And all nicotine replacement therapy medications are better than placebo. When discussing nicotine replacement therapy with patients wanting to quit, inform them that medications do prevent and relieve withdrawal symptoms. Allow time to develop strategies to avoid relapse. Allow for your controlled tapering of the nicotine, and does reduce the exposure to carcinogens and greatly will improve their success of quitting. While assisting your patients, questions may come up about electronic nicotine delivery devices, or what are commonly referred to as electronic cigarettes. On the screen, you can see the picture of an electronic cigarette. These devices come in many forms. They are disposable or rechargeable and or referrable often. It contains a cartridge filled with liquid nicotine, flavoring, and glycerin or propylene glycol. When coiled heat, it converts the contents of the cartridge into an aerosol, allowing the user to inhale this aerosol, which contains nicotine and or other substances. And that is key when you're working with your patients, to inform them that these are unregulated by the FDA, and therefore it's unclear of what is in these components or what's actually contained in the electronic nicotine delivery device. No dosage recommendations are included as they are not approved as a tobacco dependence treatment medication. There are varying levels of nicotine, even in those that claim there are no nicotine in them. They have been found to contain, in fact, high levels of nicotine. Also, as healthcare providers, you need to be aware that there are many reports by the American Association of Poison Control Centers of incidents of exposure to e-cigarette devices and nicotine refill fluids. They are very prone to causing poisonings in children and animals. As a healthcare provider, it's important that you arrange for appropriate follow-up. When individuals are trying to quit using tobacco, they need to be contacted periodically to ensure that there is not a relapse. They need this contact by your staff, and so I encourage each of you to develop a follow-up protocol, determining who is contacting the patient on what time frame, what topics will be covered. It's important during these follow-ups to assess medication use, triggers, withdrawal symptoms, remind patients of correct ways to utilize nicotine replacement therapy as prescribed, and also check in to see if they have contacted the Michigan Tobacco Quitline. At this point, I would like to revisit and talk in more detail about the assist stage. I want to discuss specific resources that are available to you as healthcare providers to assist your patients in quitting tobacco. As I said earlier, practical, personal counseling is very important when working with a patient who is trying to quit using tobacco. So please use open-ended questions to elicit information as you are providing appropriate personalized care. You'll see on the screen some very important components to cover, specifically having a conversation with a patient, asking them when the last time they used tobacco was, when they tried to quit, what nicotine replacement therapy or methods they may have utilized to try to quit is very important. You want them to talk about past successes and triggers for relapse. As you develop a quit plan with them, you want to ask questions about anticipating triggers, their challenges to staying tobacco-free. It's important to point out that alcohol use while trying to quit tobacco may lead to relapse. Also, it is important that they have support systems identified and highlight that they should limit exposure to other tobacco users. Throughout, it is important to gauge their willingness and ask them if you can share information with them. It's important that this is a conversation and that they are in a place that they want to quit and see that they have the capability and the self-efficacy to be able to quit. As you're assisting your patients in quitting tobacco, a great resource available to you within Michigan is the Michigan Tobacco Quitline. And I want to spend a couple minutes talking to you about that resource. First, I want to point out that tobacco quitlines are an evidence-based strategy to assist patients that use tobacco by increasing access to treatment and reducing barriers, because they provide assistance in multiple language and before and after normal business hours. I want to stress that they work in conjunction with physician interventions and can provide the treatment intensity that often cannot be provided in a clinical setting due to time constraints. You will also be happy to know that they provide feedback to you as a physician on patient progress. It's important that you know that tobacco quitlines are vastly different than hotlines. Hotlines are operated by volunteers and are seen as one-time emergency fixes. Tobacco quitlines are staffed by health coaches who are extensively trained in motivational interviewing techniques and are provided clinical supervision by licensed psychologists and medical directors. Quitline coaches provide their care on a patient-by-patient basis. They see the callers utilizing this service as unique individuals, and they are willing and able to work with the caller according to where they are at in the stage of change. And all calls are scheduled by the participant in order to accommodate their schedule. The Michigan Tobacco Quitline service is provided by National Jewish Health through a grant from the Michigan Department of Health and Human Services. You see the phone number here on the screen and some things that the Michigan Tobacco Quitline provide. It's key to note that the first call a patient participates in is referred to as an intake call. And these intake calls are available 24 hours a day, 365 days a year. And during this call, a patient's information and insurance status is obtained. These calls last approximately 20 minutes, and it is helpful for patients to provide this demographic information that is collected, such as marital status, race, sexual orientation, etc., because it does help assess need and aid the counselors in providing services. But this information collected is confidential, and patients can choose not to answer at any time. Patients do not need to be ready to quit in the next 30 days to use the Michigan Tobacco Quitline, but quit dates must be set within 30 days to receive nicotine replacement therapy through the Michigan Tobacco Quitline service. I will talk in more detail in a minute, but qualified enrollees and participants do receive 8 weeks of free medication, either nicotine patch or gum or the lozenge. And National Jewish Health does employ health coaches that speak Spanish and Arabic currently, and all other languages are translated real-time during the call-by language line. And the Michigan Tobacco Quitline does serve callers using all types of tobacco, including electronic nicotine delivery devices. The big question is, who can utilize the Michigan Tobacco Quitline? So you see here on the slide that all individuals in Michigan can call the Michigan Tobacco Quitline if they're using a tobacco product, and they will be provided evidence-based information and referral resources within their community. And they can participate in the text messaging program that I'll describe later in this presentation. But telephone coaching is available to Michigan residents with Medicare, Medicaid, enrollees of county health insurance plans, veterans, or those who are uninsured. These enrollees will receive personalized advice from a health coach on how to quit, information on medications, and assistance with choosing a quit date and creating a quit plan. These enrollees receive 4 coaching calls during their quit attempt, and they can contact the Michigan Tobacco Quitline health coaches between calls as needed. Health coaches assist the enrollees with identifying and reducing barriers to quitting, overcoming triggers, working on skills to reduce stress, and manage their time so that they can stay successfully tobacco-free. To clarify, on this slide you will see the list of groups of individuals who are all eligible to receive tobacco dependence counseling from the Michigan Tobacco Quitline. So you see those individuals that have Medicaid, including those that are enrolled in a specific Medicaid program referred to as MOM, or Maternity Outpatient Medical Services. Individuals with Medicare, individuals that are veterans and no proof is asked for, those individuals that are uninsured, those that have a Medicaid waiver and are part of the county health plan, anyone under the age of 18, and no insurance information is collected for these individuals. Also eligible are individuals with cancer diagnoses. Once again, no proof is requested, and all individuals who report to being pregnant at the time of the call are provided with tobacco dependence counseling through the Michigan Tobacco Quitline. Due to insurance companies changing the services they provide quite regularly, it is very difficult and time-consuming for you as healthcare providers to keep track of what every insurance company covers. So we highly recommend that you refer all your patients that are using tobacco to the Michigan Tobacco Quitline, as it is the easiest way to ensure that they have access to the services covered by their insurance. Because the Michigan Tobacco Quitline does ask about insurance status during the intake call, the health coaches are trained and very knowledgeable about what insurance companies within our state offer around tobacco dependence treatment and can refer accordingly. If individuals with private insurance do call the Michigan Tobacco Quitline, they are given information packets in the mail, as well as told about community-based resources in their area, and provided the telephone number for their insurance company so that they can find out directly what tobacco dependence treatment they are eligible for. They are not eligible for tobacco dependence treatment counseling services through the Michigan Tobacco Quitline. But once again, these insurance companies do change their covered services regularly, so please refer to the Michigan Tobacco Quitline any of your patients that are interested in quitting using tobacco. It's key to remember that currently pregnant women, individuals diagnosed with cancer, and all youth under the age of 18 are eligible for the Michigan Tobacco Quitline services regardless of insurance status. So once again, please refer to the Michigan Tobacco Quitline. I do want to take a minute to highlight the Michigan Tobacco Quitline's prenatal protocol. During the intake call, all individuals are asked whether they are pregnant, and if they answer yes, they will be given a dedicated health coach who works just with pregnant callers, and these enrollees receive 9 counseling calls. That's 5 prior to delivery and 4 calls postpartum. Because studies have shown that incentives are effective in increasing participation and changing behavior in the prenatal population, enrollees receive a $5 gift card for each prenatal call completed and a $10 gift card for each postpartum call completed. And they're eligible for a maximum of $65 if all their counseling appointments are completed. So once again, if you have pregnant patients that are using tobacco, please refer them to the Michigan Tobacco Quitline. They will be able to be provided counseling services that will drastically increase their chance of quitting. A little more about the Michigan Tobacco Quitline and their new online services. There's a website, as you see listed here on this slide, that is tied to the Michigan Tobacco Quitline, and it benefits individuals greatly as they can complete an enrollment form here through this portal, and that initial phone intake call will be shorter than the previously mentioned 20 minutes. Also, users can use this website to access a dashboard where they can create a quit plan, they can track their tobacco use, they can participate in online chats and forums, they can access e-lessons and worksheets that help them to journal and formulate goals. It is a plethora of information that will assist individuals in Michigan that want to quit using tobacco, provides lots of resources to support them in their quit attempt, and is free. In addition to the online program, there's a new text messaging function that's available to individuals that enroll with the Michigan Tobacco Quitline. There's a library of over 300 messages, and these are evidence-based messages and are done in a two-way messaging format, meaning that enrollees do get messages as well as they can respond to those messages. And these messages are developed to provide support, prevent relapse, offer tips and motivation and encouragement. And they are customized by tobacco type and really supplement the online portion or the over-the-phone counseling appointment. This is an opt-in that is asked of all enrollees during the intake call. The Michigan Tobacco Quitline health coaches also ask about nicotine replacement therapy when they are speaking with callers. And free nicotine replacement therapy is available to enrollees who are uninsured, on Medicare, being treated for cancer, are pregnant, and have a doctor-signed approval. So once again, if an individual is pregnant, has recently had a heart attack, and wants nicotine replacement therapy, they do need a doctor-signed approval. But patches, gums, and lozenges are offered to eligible groups. Up to 8 weeks of nicotine replacement therapy is available and shipped directly to the patient's home. That, of course, is only available to callers that are 18 and older. And it is important to note that individuals must enroll in the Michigan Tobacco Quitline counseling services and speak with a health coach to receive this nicotine replacement therapy. So how do you refer to the Michigan Tobacco Quitline? Currently, the best way to do this is through a fax referral form. And these fax referral forms are available online at the address listed on the screen, and they can be downloaded and completed and then faxed to the National Jewish Health offices to enroll your patients in the Michigan Tobacco Quitline. Nurses, medical assistants, social workers, dentists, anybody can refer to the Michigan Tobacco Quitline using the fax referral form. Within one business day of receiving the referral form, National Jewish Health will attempt to contact the patient and use the date and time and the phone number provided by you on the fax referral form. Healthcare providers who refer patients to the Michigan Tobacco Quitline via fax referral will receive a follow-up report on the patient's progress. So providers will get a fax back when the referral form is received by National Jewish Health. They'll get a fax back when the patient enrolls. They will get one when the patient receives nicotine replacement therapy and when the patient completes the program or if the patient is unreachable. And I highly suggest that healthcare providers do put these faxes that they get back from National Jewish Health in that patient's medical record. And once again, I want to stress that a provider's signature is only required on the referral fax form when the patient has uncontrolled high blood pressure, a recent heart attack, or is pregnant and wants nicotine replacement therapy from the Michigan Tobacco Quitline. This is what the fax referral form looks like, and because this form must be printed out and faxed to National Jewish Health, it is important to fill it out clearly and completely. Specifically under the provider section, it is imperative to write a contact name of the person to receive patient feedback or an individual in that office who can clarify patient contact information. This can be a receptionist, a nurse, or medical records staff. It does not need to be a physician. The healthcare provider licensed to prescribe in the state of Michigan must sign the form. As I stated before, if the patient is pregnant, has uncontrolled high blood pressure, or has had a recent heart attack and wants nicotine replacement therapy. Under the patient section, there is a place for the patient to initial that they've agreed to be contacted by the Michigan Tobacco Quitline, and a place for them to put their phone number in. And it's imperative that this phone number be written clearly so that the Michigan Tobacco Quitline can reach out and call that patient. I do want to highlight that there are currently ways that patients can be referred to the Michigan Tobacco Quitline electronically as well. And that functionality is being created so that healthcare providers can refer directly from their electronic health record to National Jewish Health. And that functionality is being created and is on the horizon. Some health systems are currently trying that and being a pilot for that capability. And so hopefully that will reduce a lot of human error that we get on completing the fax referral and will increase the chances that individuals in Michigan wanting to quit utilizing the Michigan Tobacco Quitline services are able to do so, as it will make it easier for National Jewish Health to contact patients, communicate back with healthcare providers. So right now, Michigan Health Information Exchange is working with National Jewish Health to increase the capacity in electronic health records to do electronic referrals. But until that is system-wide and more widely utilized within our state, we want to encourage still the use of the old paper-style fax referral form as a way for you to refer your patients to the Michigan Tobacco Quitline. On the screen, you will see my contact information, and I am available as a resource to everybody living and working in Michigan regarding tobacco dependence treatment and any health systems changes that need to be done to ensure that tobacco dependence treatment is being implemented within the health system. So if you have questions or concerns, you may contact me directly after this presentation. Thank you.
Thank you so much, Patricia. At this time, we'd like to have the ball passed to Dr. McCabe for her presentation.
Thank you. So I've had the pleasure of working with Patricia for the last year and a half with systems change within our 5 hospitals and how we do it. So by admission, I am a former smoker. I smoked a pack a day from the age of 12 on. I've intermittently smoked throughout my career, and it's just a reminder that even as a thoracic surgeon who specialized in lung cancer, and now I manage the regional lung cancer program as well as the nodule program and tobacco cessation, it is always on a smoker's list of options to use. So let's start going through this. I have a little bit of a different style because a lot of our program is based on how to engage other people into being part of the solution. So one of the things we do before all our meetings is we always start with some kind of a reflection, some way to be mindful about why we're all here. And this was something I recently heard, and it's to stay small but radiate big. And I think that's really true for tobacco cessation. We need to really be the patient's advocate. We need to partner with them. We need to be accessible. We need to not blame. And then we need to radiate all of the system change big so that we can help as many people within our communities as we can. So just some general kind of information. And these facts are always very engaging into presentations, so I thought I'd run through a couple of them. Tobacco use, nobody's immune from the effects of tobacco smoke. Claimed the lives of many American icons, and it was really Dana Reeves that emphasized the toxic effects of environmental tobacco smoke, since her lung cancer was thought to be due to secondhand smoke, to the public. We advertise to women, and I always put this slide up to remind myself that my husband's great-grandmother was one of the Chesterfield models, and so even within our families, it's surprising when we look back and forth. Oh, there we go. We advertise to minorities. We make it look glamorous to women. But we have had some campaigns. I'm not sure why we're jumping around here, but let me keep going, to try to curb it. So in the early 2000s, this was a campaign put out in 17 magazine to try to discourage young women from smoking. It was very effective. This was a $21 million anti-smoking campaign in California, highlighting the effects for men. And by the way, every Marlboro man has died from lung cancer and tobacco use. So in 2015, about 15 of every 100 U.S. adults aged 18 or older currently smoke cigarettes. That's about 36.5 million adults in the U.S., and more than 16 million live with a smoking-related disease. So Patricia went over what current smokers are, so we can just keep moving through that. And really, this is a great statement about tobacco. So a cigarette is the only consumer product that, when used, directly kills its consumer. And this was from the former Prime Minister of Norway and former Director General of the World Health Organization. It is responsible for about 480,000 deaths per year. It's the most lethal of all cancers in men and women, more lethal than the top 3 cancers for women and the top 2 for men. And really, the Midwest, interestingly enough, has the highest smoking rates. Secondhand smoke is a really important thing to emphasize in your campaigns of education, and especially for educating patients as well. Heart disease for non-smokers breathing secondhand smoke has immediate harmful effects on the heart and blood vessels that are almost the same as the person smoking. It's estimated that secondhand smoke causes about 34,000 deaths now, upwards of the 40,000. And lung cancer can also be attributed to secondhand smoke, as can stroke. Kids have more ear infections. We see more frequent and severe asthma attacks, as well as admissions in both kids and adults. More respiratory symptoms in kids living with smokers, respiratory infection, and greater risk for sudden infant death syndrome. There's a couple studies out there that looked at cotinine levels in kids who just live with smokers who say they don't smoke in the house, and they had measurable amounts of cotinine. So there are, of course, other forms of tobacco. I know Patricia went over many of those, but really 96% of sales for manufactured tobacco worldwide is due to cigarettes. And just one thing we always talk about in our education campaigns for our younger people is that 3 hours in a hookah bar is 45 minutes in a hookah bar is the equivalent of 3 packs of cigarettes. So understanding how to convert the doses is also important as you go through educating your team. It's important to realize that it's the combustion of nicotine that causes the release of the chemical. You know, there's 69 of these chemicals that cause all forms of cancer. In fact, 25% of cancers are linked to tobacco, not just lung cancer. Patricia has already talked about e-cigarettes. The most interesting thing is we're putting out a piece in Pediatrics coming up where we did a cross-sectional study of adolescents. 30% of adolescents, 8th graders, have tried e-cigarettes. Most of them try e-cigarettes first, as Patricia mentioned. They are now, as of 2016, going to start being regulated. And the problem is it's often a gateway to tobacco and other drugs. So more studies on that. The lung cancer risk with e-cigarettes we think is only going to come out in about 10 to 20 years. There's a long latency period. And I'm often asked the question about marijuana as well. Again, we think it's the combustion of whatever plant it is, so not recommended to be smoking. An interesting thing about the tobacco business, and this is a quote from the former Director General of the World Health, is that Marlboro used to put ammonia to make the freebase version of the cigarette into its manufacturing process. And this was one of the greatest triumphs in the history of modern drug design, and one reason that Marlboro became the world's most popular cigarette. So when you put the freebase form in, or it has an ammonia attached to it, you get much quicker delivery and heighten the addictive potential. So it really takes a village when we're talking population health, tobacco cessation, and really educating your providers at all levels that even to clinician types, doesn't have to be physicians, can be the CT techs, because our CT techs are now educated to ask about smoking and talk to the patient. It increases your odds ratio of effectiveness and estimated abstinence rates by up to 2.5 times. So, how do you help patients quit? Well, what doesn't work, threats, shaming, force, judgment. You're going to die from your MI or your lung cancer. It just doesn't work. Motivational interviewing is something we teach to our nurses and the people involved in the specialties that touch these patients the most. So the primary care offices, the lung screening navigators, we are in the process of teaching it to our cardiac rehab coaches. And really, this technique has been shown to increase quit attempts by 30%. It uses the patient's personal motivations and priorities to empower them to quit. And it's non-confrontational. That allows for increased accountability between the patients and their providers. Patricia had gone over the 5 A's. No need to belabor that. So I'm going to skip through these. And this is, I think, an important tool in the assessment. So how important is it for a patient to quit? And virtually all smokers, not all, but most, will say it's very highly important, sign a 7 to 9. Confidence to quit remains low. The nice thing is, as you have tobacco programs and you're counseling these patients, it's so nice when this is in your medical record to pull this up and show the patient their progress. Like, wow, look, you're 3 months into being abstinent. You had zero confidence to quit, but you really wanted to. Well done. And then the last A, of course, is the arrangement for follow-up care. So what does work? Empowering the patient, empathy, so not sympathy, right? Sympathy is when, say somebody says, gosh, my daughter has all F's in school, and the other person will say, at least you have a daughter, or at least your son has all A's. And so really what we want to do when we're being empathetic is listen and understand how hard it is and not shame or blame, because the person is already doing that for themselves. So a couple things that were really important as we have partnered with the state and our county were to really map the process within our clinics and identify barriers. So on the inpatient side, for instance, oftentimes in the medical record, either there's the wrong PCP, no PCP, the ICU nurses weren't educated, the residents, some of the attendings, we had poor documentation if somebody comes in an urgent situation. And nationally, we know that only about 30% of EHRs actually have reasonable documentation. I know the HEDIS metrics tend to be higher, but when you're actually cross-checking them with databases that are working, it's much lower. It shouldn't be just a tick, in a box to get reimbursement. This really should be about helping the patients with this terrible problem. On the outpatient side, what we found was we were doing paper referrals to the Quitline. Our EHR was lacking in that the tobacco template was lacking. It wasn't facilitated for the MAs to use. We had a lack of metrics that could be pulled, and we uncovered many educational opportunities. So through the guidance of the state and Washtenaw County and Patricia Heiler and others, we actually are in the process of currently testing our e-referral to the state Quitline, and hopefully have that up and running completely within the next 1 to 2 weeks. I was disheartened really to hear that there was no other provider or center that had e-referrals to the Quitline. And so this is an incredibly large effort to change an EHR. When we walked into this grant, we had no understanding of how big this ask was. A year into it, we're starting to get there, but this is for certain about stamina. So this is how we've remapped the flow in our clinics. The MAA asks, do you currently use tobacco products? If yes, and they're interested in talking about quitting, then we ask if they're interested about quitting within the next 30 days. If they say nope, we document it and continue to ask at their next visit and every opportunity. If they say yes, then what we do is we leave a pamphlet with the patient's chart or their paperwork that talks about smoking and some of the resources, so that the provider, when they're walking in there, knows that, hey, this is a smoker who either wants to quit or is planning to quit. Take the 60 to 120 seconds to talk to them about this, and then we go through the rest of the algorithm. So we are also very aggressive about using medications. And I'd say the biggest problem is in underprescribing. So let's switch gears and talk a little bit about the biology of nicotine dependence and pharmacology. So we know smoking leads to upregulation of nicotinic acetylcholine receptors in the brain, including the alpha-4 beta-2 receptor, which is really the site which Chantix hits. So nicotine reaches your brain within 8 to 11 seconds, binding to these receptors, and leads to satisfaction of urges and cravings to smoke. There is no other delivery system that is as streamlined as smoking a cigarette. So after quitting, and this is important for your providers to understand, it takes 3 months of time for nicotinic receptors to return to their normal state. It's important to kind of cement that, because that's how we decide, that's how you guide therapy. Another nice thing providers like to know is about the neurotransmitters that are influenced by nicotine and the impact on the human body. So dopamine is where pleasure and appetite suppression come in. Norepinephrine, arousal, appetite suppression. Choline, arousal, and cognitive enhancement, right? So when smokers tell us, I'm calmer, I don't eat as much, I concentrate better after a cigarette, and I have reduced anxiety, it's true. They do. When we withdraw, we tend to be anxious, hungry, irritable, depressed, restless, we can't sleep, and we have poor concentration. It's not infrequent that when we prescribe medications, sometimes these symptoms get confused, so it's worth a discussion to help educate patients. We also try to really enforce with our providers and other people the benefits of quitting, right? 20 minutes after quitting, your heart rate drops. A year after, your risk of coronary heart disease is half of that of a non-smoker. After 15 years, it takes 15 years after quitting, your risk of coronary disease is back to that of a non-smoker. The risk of lung cancer never gets back to zero, or of head and neck cancers or other cancers related to smoking, but it gets to about half that at 10 years of cessation. So one of the kickbacks we often get from providers and patients is that, I'm just replacing one addiction with another by using nicotine replacement therapy. Well, this is an education issue, so it's really helpful to point out that nicotine replacement therapy does not contain toxins that are found in smoke. It's not carcinogenic. I've had one patient who's been chewing nicotine gum for 20 years since quitting, and that's great, and that's what he wants to do. It allows for gradual, controlled absorption of nicotine into the bloodstream, so this is really important to help patients understand that they're not going to get that same release as they get from an inhalation off the cigarette. And replacement therapy relies on venous absorption as opposed to rapid arterial absorption. So really the two parts of smoking addiction that we're treating are the situational cravings, right? I get up, I have a cup of coffee on a cold fall morning, I think of having a cigarette immediately, and the physiologic cravings. I'm grouchy, irritable, I can't concentrate, and I want to eat. We talked about non-pharmacologic, and I think Patricia did a beautiful job of outlining how the state quitline works and what a great job they do, and then we're going to focus a little bit about pharmacology. But what's really important is that counseling and medication together, the combination, is more effective than either alone. So your chance of quitting cold turkey for 6 months is 4%. Now we'll go through and look at some of those statistics as we quit using assistance. So we talked about the three classes, nicotine replacement. We tend, in our practice, not to use sprays or inhalers. They tend to be more rapidly delivered, and so you get the swings you get with cigarettes as well. It's just a bias of ours. We use a lot of Zyvana and Chantix. And really, patients should theoretically stop using all forms of tobacco upon initiation of the NRT regimen. Most of them who don't are underdosed, and that's why they continue to use. So the rationale for using nicotine replacement therapy is drop the withdrawal, eliminate immediate reinforcing effects of nicotine, allows the patient to focus on behavioral changes. And remember, each cigarette contains about 1 to 2 milligrams of nicotine. So here's a graph, and our providers love seeing this, and here's the rapid uptake with the cigarette in that teal color, and the patch is the straight line at the bottom. So as you go and you're looking at concentrations at 60 minutes, you're really at about a fourth or a fifth of the concentration of one inhaled cigarette. And so that's why when patients say it didn't work for me, they haven't been really explained that. It's not going to replace the cigarette. It's just going to help with some of your symptoms. So a couple of precautions. Patients with underlying cardiovascular disease. So I'm a thoracic surgeon by training, and aside from people who have arterial grafts that are fresh as part of their coronary artery bypass grafting. We use this on all our patients who get NRT replacement in the hospital. Really the contraindications on the labels are recent MI within the past 2 weeks, serious arrhythmias, or unstable or escalating angina. There's been no studies to look at that. There has been one really well done randomized prospective trial in multiple centers where they looked at giving Chantix to cardiovascular patients, and it was safe, didn't increase mortality from MI, stroke, or death. It's important during your education campaigns to talk about doses, when you start tapering, and that you really need to go at least to 12 weeks. There's some newer data saying Chantix may, some people do better if you continue it to 6 months. We give people these types of outlines, and we have a cheat sheet that we've developed and we hand out to our providers whenever we go speak on this, because it's helpful to them to have a pocket guide, and this was specifically something they had asked for. It's important to educate patients about transdermally how to choose a new spot to make sure the skin is clean and dry, and to not use the same area for a week. When you really educate people about where and how to put the patch, 50% may experience some mild local skin reactions, but only 5% discontinue this. It's important to tell people to remove the patch before MRI procedures and to never cut the patch to adjust dose, because it renders the patch inactive, so it doesn't help anymore. I'm going to skip over these because I'd like to leave some time for questions. So here's some of the long-term greater than 6 months quit rates for cessation medications. And here you can see the Chantix at the rightmost, 20% versus a placebo of 11%. Multiple quit attempts are normal. And Patricia, to me, the most important thing she said was this, and on average it's 4 to 7 quit attempts before a person is successful. And if they fail on one agent, you can try the same agent again or later. You need to maximize their success rates with counseling and behavior modification, and it is always on the patient's medical history. Tobacco use is a chronic disease, and it's always an option for the patient in handling stress or celebrating the good times or for no reason at all. So that is an incredibly a different way of thinking about tobacco than traditionally people have been taught, and especially in recording in our EHRs. Oh, they quit smoking, off the list. Nope, that needs to stay on the list. And again, just to really focus, quit attempts, 4 to 7. So what about cost? People say, well, it's really expensive. When we look at the average pack of cigarettes in 2015 was 6.54, what we can see is almost all of these therapies are significantly less. And then with the assistance from the Quitline that Patricia went over, we can drop these even some more. So what's new on the horizon? There's a new molecule, Cessation. It's been talked about in the New England Journal, where they did a study on 1,300 smokers for 1 to 6 months. It appears to be at least as effective as, I believe it was compared to Chantix, but cost significantly less. Limitations were people had to buy it on their own, and it was only done through word of mouth. Also, there's some new data looking at biomarkers. So there's something called a nicotine metabolic ratio, and this was talked about in Lancet Respiratory Medicine. And what they found is that slow nicotine metabolism, nicotine replacement therapy is preferred. They do better. And with normal nicotine metabolism, Chantix is preferred. That's certainly not available in most labs, but some stuff to watch out for. We've really appreciated the opportunity to partner with the state of Michigan and their expertise in helping us design our EHRs, the e-referrals, as well as the whole paradigm shift within our health system. Our grant has really targeted 3 clinics, Neighborhood Health, which is a underserved clinic with much higher smoking rates, our academic OB-GYN clinic, as we're seeing increased rates of smoking in our pregnant population, The most interesting thing there is to remember that the patients after they have babies tend to relapse. It's not typically during pregnancy. The other thing for the pregnant population is this is the one case where cutting down, especially within the first trimester, actually improves outcomes and should be part of the recommendation. And then looking at our lung cancer screening and nodule population. So those are kind of the low-lying fruit within our system because those patients are really motivated to quit. We're happy to say we are almost done with our beta testing of the e-referral within our multi-specialty practice in the West Market of the St. Joe's 5 hospitals. So the other areas where we've identified some need where we're starting to focus are how do we really assist the PCPs? It's not realistic to think each PCP office is going to have a champion. How do we help the cardiologists, and can we partner with them in their cardiac rehab program? Lung cancer screening has mandated tobacco cessation counseling or referral. How do we do that better and get better metrics and kind of keep this ball rolling within the cancer centers, linking it to our inpatient populations as well as our pulmonary populations? We have to keep really thinking about innovation and care delivery. So mainly what I do is I translate clinical medicine into finance to be able to fund these programs. And I think this is really an opportunity for innovation using evidence-based practices for the patient. One of the things that we did find was that it is very helpful to have champions. You need physician champions, nursing champions, executive champions, and diets to get these programs through, and the patient should be on that team of champions. This is a marathon. This is really, smoking cessation takes stamina, and we have to follow Usain Bolt's example to kind of smile as we're running through this. It's a lot of work, and if we just stay positive, we can make a big difference. And remember, water's the strongest element, so water dripping can carve a rock. And as we go through tobacco cessation within our health system, at times it feels overwhelming. But we need to look at the rocks or the barriers in our way as opportunities to look at new innovations, partnering with our patients, partnering with insurers, because this is the single most important thing that we can do to change our population health in communities is to help with tobacco cessation. So as we continue to partner in health and wellness, we certainly welcome any questions, and I think we're going to be doing that through the chat, and we really appreciate your time today.
Wonderful. Thank you so much to both Patricia and to Dr. McCabe. At this time, we would like to make evaluation questions available to all attendees. Please take a moment to let us know your thoughts on today's session, because we do use participant feedback from these evaluations in the planning of our future sessions. Also at this time, we would like to open the line for any questions that participants might have for Patricia or for Dr. McCabe.
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. And ladies, I'm waiting for callers to join the queue at this present time. We don't have anyone in queue at this present time.
One thing is, Dr. McCabe, I just wanted to mention to people that I forgot to mention was that it's important to tell your patients that when the state quitline calls back, it's an 800 number. What we found in following up all our referrals is that patients don't answer 800 numbers as we don't, and so knowing that is helpful. I know that the state quitline is working on getting their caller ID changed to Michigan State Quitline, which I think will help prevent one of those barriers. The second thing was that we found in the lung cancer screening and nodule patients, 70% of those patients were not eligible for the person-to-person counseling. And so it's an opportunity for a health system to look at that area especially.
Did we have any questions from any of our participants today?
We still don't have any callers in queue at this present time.
Okay. Well, in the interest of time, again, I'd like to thank Patricia and Dr. McCabe for taking the time to speak with us today, and also to all of our attendees, thank you for joining us as well. These slides from today's presentation will be available on MPRO's website and our YouTube channel within the next week. We also do have a few helpful resource documents supplied by Patricia relating to the Michigan Tobacco Quitline fax referral form, and also tobacco dependence treatment and patient and provider resources. These should appear on the registration and event access page, although if you did not see those before, we'll be sending them out to all attendees following this session as well. And also be sure to join us for our upcoming webinar on March 14th entitled Colorectal Cancer Screenings, Evidence-Based Recommendations and Best Practices, and this will be held at the same time as today from noon to 1 p.m. And if there are no other comments or questions, that concludes our session for today. Thank you so much for joining.